Assalamu alaikum. My name is Razan. I'm a third year medical student. Inshallah, for today, I'll be giving these three sessions, inshallah, for your MOL midterm. Please feel free to contact me if you have any questions. And Ramadan Mubarak عليكم وإن شاء الله الله يتقبل صيامنا وقيامنا وجميع صالح أعمالنا يا رب. Okay, with no further ado, we can start. So I'm going to cover the metabolic effects of insulin and glucagon, fed and fast cycle, metabolism in diabetes. طيب, the first lecture, and here we go, inshallah. طيب, fuel and homeostasis are coordinated across these four tissues. We have the liver, then the muscles and adipose and the brain. طيب, in the liver needs to maintain our blood fuel. And how is that? It's by glucose and ketones. Glucose is during the fasting state, and the ketones when we are starving. For muscles, they use and store, but they don't supply the body with the fuel. Why is that? Because the muscle lacks the enzyme glucose 6-phosphatase. And for the adipose tissue, it stores and releases triacylglycerides when our body needs them in the prolonged fasting. Also, the brain needs to utilize glucose for its energy, and in prolonged fasting or starvation, it's going to utilize ketones. Also, as you know from our endorepro block, that the communication between tissues is mediated by hormones and substrates when they are available. Okay, so insulin and glucagon balance drives metabolism. طيب, in fed state, we have the insulin, and the insulin is high during this fed state, and this where we store our energy, like we store the glucose, fatty acids, and to get energy later on. During fasting or stress, we're going to have the glucagon plus or minus epinephrine if there is stress in that case, and we're going to mobilize them. Our goal here, we need to maintain the blood glucose and supply the energy to the tissues. Okay. So insulin, we know it's an anabolic hormone, so we are going to store. And this occurs during the fed state. So where do we get the insulin? We get it from the beta cells, specifically from the islets of Langerhans. So the pancreas is composed of two things, the endocrine and exocrine. 1 to 2% is the endocrine part, and the rest, 98% or 99%, is the exocrine part, which is related to the GI. So what triggers the insulin release from the islets of Langerhans? It's the blood glucose. This is the major trigger for the insulin release. Also, we can have amino acids and incretins, and these incretins are released from the intestines to increase the insulin release from the beta cells. What's the effect of that? We're going to have increased glycogen storage, like the glucose is going to be converted into glycogen and get to be stored. Also, triacylglycerides and protein synthesis is going to be there, but we don't store proteins, we just synthesize them and use it directly. Like, we need to know the structure of the insulin. So here we have chain A and chain B. Insulin is composed of two chains. Chain A is composed of 21 amino acids, and chain B is composed of 30 amino acids. These two chains are linked together by disulfide bond. So we have the intramolecular is in one chain, like this chain A here has an intramolecular, and it's called intramolecular disulfide bond, and it's between the cysteine residues. The other bond is called the intermolecular disulfide bond between the cysteine residues in both chains, here and here. Like, the insulin, we need to know how it's processed. So it's processed via the rough endoplasmic reticulum and the Golgi apparatus. So first we start by the pre-proinsulin, which is made by the ribosomes from the rough endoplasmic reticulum. Then this pre-proinsulin is going to be oxidized, specifically the cysteine residues, and get cleaved, and we remove from it the signaling sequence in the endoplasmic reticulum, giving us the proinsulin. This proinsulin is going to be transported from the rough endoplasmic reticulum to Golgi apparatus. Before it's going to Golgi apparatus, we're going to cleave or remove the C-peptide in Golgi, and then we put it in, or it's going to be put in a secretory granule. There is a clinical significance of the C-peptide in patients who are taking exogenous insulin or insulin from outside, like in type 1 diabetes. They don't get the C-peptide. So if you want to know if this person has insulin, endogenous insulin, we're going to measure the C-peptide because it has longer half-life and it's secreted in an equimolar amount with the insulin. Also, you need to know that C-peptide helps in folding. So also when you see in my slides a pin sign or any thing that's colored in red, it's high yield and you need to know it. This is also a summary from what I just summarized here. If you want to go over it, you can, but what I mentioned is the thing that you need to know. So here, you need to know that insulin has a short half-life. It's just 6 minutes, like has a rapid on and off control, like rapid, we just want to regulate the glucose levels, and off, خلاص, we don't want patient to have hypoglycemia. And we said that the major stimulus is glucose, a little bit of amino acids, and incretins, which are GLP-1 and GIP. So here, the regulation of insulin, when you have glucose, you can see this, as we said, it's the major inducer of insulin. It has this bolded arrow, and also amino acids and fats, they induce insulin. Epinephrine inhibits insulin, like when you're in fight and flight state. Epinephrine inhibits insulin even if blood glucose is high to protect the blood glucose from getting lower. Yes, exactly. You're right. Epinephrine inhibits insulin. Then here you have these GLUT transporters. They're very high yield and you need to know them. Like you need to know which GLUT transporter is present in which organ. Like here we have GLUT4 is insulin dependent, and this is very important, as we will see later. It's found in the skeletal muscles and in adipose tissues. GLUT2, you need to know, since you can see here it's 2 just as a mnemonic, 2, and here it's bidirectional, 2 with bidirectional, like 2 sides. It's present in the liver and the beta pancreatic beta cells. Also, GLUT2 is a glucose sensor. When it senses glucose, it's going to be activated, especially in beta cells, where the insulin secretion will be started. GLUT1 is found in the RBCs and the blood-brain barrier. GLUT3 is found in neurons and in the brain. It has high affinity when glucose is there. GLUT5, fructose, you can remember it, 5 starts with an F, and here fructose F. It's found in the small intestine and in the sperm. Again, here, an important thing, that's GLUT4 is the only one that needs insulin. Here was a mnemonic in your slides from Dr. Hana. I think it's nice. You can just memorize it from here. But the most important ones, as I said, is GLUT4 and GLUT2. Right, now we need to know how is insulin released. Yeah, Muhammad, yeah, right. طيب, insulin released, so we need to have glucose. Here we have GLUT2. We said GLUT2 is found in the beta pancreatic cells and in the liver. طيب, here we have the glucose. You ate your meal. There is glucose in your blood. These GLUT2 transporters senses glucose, and glucose enters to the pancreatic beta cells. In glycolysis, you have the 2 enzymes, hexokinase and glucokinase, but the most important one is glucokinase. This glucokinase enzyme, also we can call it a glucose sensor as GLUT2. Tamam? Then during glycolysis, you're going to produce ATP. This ATP is going to inhibit this channel. It's called ATP-gated potassium channel. Inhibiting this is going to cause depolarization in the cell. By that, you're going to get calcium influx by opening the voltage-gated calcium channels, and also calcium getting out from the endoplasmic reticulum. And as the process I explained earlier, in the rough endoplasmic reticulum, we have the insulin granules where we have the insulin and C-peptide in these granules, and they're going to be secreted. Here is just what I explained in the picture. You can go over it. Also, the glucokinase, I just mentioned that it's glucose sensor as GLUT2. The more glucose you have, the more ATP and the more insulin secretion. Like from this graph, you need to know that first thing here, you have the enzyme activity, and here you have the glucose concentration. Hexokinase is found in other all other tissues other than the pancreas and the liver. So when you are fasting, here, let's say here you took a meal. Here, the glucokinase will be low. It has low affinity when there is no glucose. When there is no glucose, it has very low affinity. But once you eat, it's going to increase and work at its maximum capacity. On the other hand, hexokinase, when there is no glucose, here it's going to be increased and to get the supply for RBCs and the brain, especially because they work on glucose. But when there is much of glucose, it's going to be sustained, and it has very low Vmax. So high Km, which is the affinity of glucokinase, and the high Vmax also for glucokinase. On the other hand, hexokinase has low Km and has low Vmax. We just went, okay, here's a question. High Km, low affinity. Yeah, so when you have high Km, basically glucokinase, when there is a lot of a lot of glucose, it's going to work at its maximum capacity. But when there is less glucose, hexokinase will work more than glucokinase. Did you get that? Okay, great. Like incretins, they amplify the insulin when we take oral glucose. So if I told you, as I mentioned earlier, the incretins are GLP-1 and GIP. So if we gave a patient or a normal individual glucose orally, and we gave another one IV, which one do you think we're going to have incretin effect, or like increase in the release of, sorry, I apologize, the increase in insulin release? The person who got the oral or IV? Yes, exactly, oral. You are right. Like this is the idea from this slide. Oral glucose will trigger the release of insulin more than the IV glucose. Next, here we have the insulin effect, like when during fasting and during stress. So in fasting, there will be low secretion of insulin. Why is that? Because we want to conserve the blood glucose. We don't want to have hypoglycemia. Also, the same thing during stress and exercise. So even if your blood glucose is high, but you are in stress or you are exercising, epinephrine is going to be released, and by that it's going to inhibit the insulin release. So what we call it, in other terms, sympathetic input overrides the glucose sensation in beta cells. And that is because we want to mobilize fuel from the hepatocytes or the liver, and also increase the lipolysis, which is the breakdown of fatty acids. And this is also, I just mentioned it, that in stress or exercise, the insulin is going to be inhibited by epinephrine or norepinephrine. Like again, as I mentioned, if you see a pin sign or in red, you need to know it. So the effects of insulin and carbohydrates. So in the liver, we would have decrease in gluconeogenesis. Does anyone of you know what does gluconeogenesis mean? Yeah, making basically glucose, but making glucose from non-carbohydrate sources. Non-carbohydrate sources means like from glycerol, from lactate, from amino acids. Okay, so here we don't have making that. Is going to be activated later when we see, inshallah, in starvation in a bit. And we have also decrease in glycogenolysis. Glycogenolysis means the breakdown of glycogen. And by this, we have decrease in glucose output. So because insulin is anabolic. We're storing more than we are mobilizing. Also, the effect of insulin on liver and muscles, both of them, they store glycogen, but later when we need energy, we're going to get it from the liver, not from the muscles, because the muscles lack glucose 6-phosphatase. Also, the effect of insulin in muscle and adipose tissue, it increased the uptake of glucose via GLUT4 and GLUT4 translocation, as we'll see in a bit, inshallah. Here it is. Okay, I think there's a question. Yeah, GLUT4 is insulin dependent. Yes, right. Like, here we have the insulin, its receptor, which will lead to these GLUT4 transporters to come to the membrane and fuse with the cell membrane, and getting exposed. So they will lead to the insulin getting in to store it. And when we get the glucose inside, these vesicles are going to get inside, and they're going to fuse together and forming an endosome, and again getting recycled when there is insulin binding here. Also make sure that the liver doesn't use GLUT4 because takes glucose independently. They uptake it just independently. They don't need any of these transporters. Is that clear? Okay, great. Like the next is the effect of insulin on lipid metabolism. So you have two enzymes, which is hormone-sensitive lipase and lipoprotein lipase. You're going to dig more deep, inshallah, with Dr. Abdul Jabbar after your midterm, inshallah. You're going to have any separate lectures on these. So hormone-sensitive lipase, this is an enzyme. It's going to mobilize the fat, like when you need energy. It's going to break down fat, and this fat is going to be used as an energy. But lipoprotein lipase, you're going to use it, or it's going to be activated to get the energy or to store the energy. And how is that? It's going to uptake the fatty acids from the chylomicrons. These chylomicrons are your dietary fat, the fat that you eat. And the VLDL is just the fat that is stored from the liver, especially triglycerides that are packed up in this VLDL, and you store this fat as triacylglycerides. So as a summary, hormone-sensitive lipase is inhibited by insulin. Lipoprotein lipase enzyme is going to be activated by insulin. Also, the effect of insulin on protein synthesis, it's going to increase the amino acid uptake into the cells, which leads to protein synthesis. And by that, we decrease the net breakdown of proteins. Protein synthesis doesn't mean that we're going to store proteins, because proteins are not stored. Is that okay? Again, here, this is a summary about what we said about the insulin. You need to know where this glycogenolysis is increased, gluconeogenesis, lipolysis, and all of this. Again, this is a summary. Then we go to glucagon. So glucagon works opposite to insulin. طيب, so it means that here glucagon is going to mobilize the stored energy, or stored stored energy, so we can get our energy from them. So here, glucagon is excreted from alpha cells from the pancreatic islets. Its major role is to maintain the blood glucose during fasting. Like now in Ramadan, when we are fasting, we get our energy from the glucose that is stored. It primarily acts on the liver. So we start by glycogenolysis. First, we break down the stored glycogen. Then, if someone is fasting more than 18 hours, gluconeogenesis will kick in, which is synthesis of glucose from non-carbohydrate sources. We have also other hormones that play a role with glucagon, which are epinephrine, cortisol, and growth hormones. All of these hormones, they counteract insulin. So insulin is the only hormone that can reduce blood sugar, but increasing or maintaining the blood sugar, increasing it, can happen by these four hormones. So this is not that much important. The glucagon is made up of single chain 29 amino acids. It's made as pre-pro glucagon. It has short half-life, and it's primarily targeting the liver. And its net effect is catabolic, and insulin is anabolic. Okay, so insulin effect. The fat. Yeah, so insulin, yeah, inhibits hormone-sensitive lipase, so we have less breakdown. Exactly, you're right. And it stimulates lipoprotein lipase, so we store fat. Did you get that? Okay, great. So we have triggers, as we had triggers for insulin. The triggers for glucagon is reduced blood glucose. Glucose is the primary trigger, either for insulin or for glucagon. Also, they found that the amino acids after protein meal, like if you ate a rich protein meal, the amino acids from that meal are going to cause glucagon rise and insulin rise. So they by this would prevent the hypoglycemia that would occur from the amino acids. So if they asked you what dietary component would lead to the release of both insulin and glucagon, that would be yes, amino acids or proteins, basically. طيب, the last trigger for glucagon is stress, like catecholamines. Catecholamines work with glucagon, so they increase their levels with glucagon, which leads to maintain the blood glucose, and also they inhibit insulin secretion. This could be also as a question, as your doctor stressed on it. She said, like you have to know that catecholamines, epinephrine or norepinephrine, they inhibit the insulin secretion. Here, just again, a summary: glucose and insulin, they inhibit glucagon release. Epinephrine and amino acids, they stimulate glucagon release. Again, here are the effects of glucagon. Glucagon increases the glycogenolysis. It's very rapid, works within minutes, or you can say acutely. Gluconeogenesis, it's very slow and sustained. Then also you have the fatty acid oxidation, which is the breakdown of fatty acids. And from fatty acids also you can have ketone bodies are formed, and this is, could be in prolonged fasting. Also, from glycogenolysis, you have the hepatic uptake of amino acids, as we said, gluconeogenesis. Uh, we f- uh, it's kicking by the amino acids and glycerol and lactate. These three substrates are direct substrates for gluconeogenesis to occur. And by that, if you check the plasma amino acids or serum amino acids, is going to be decreased. So the mechanism of action of glucagon, you need to know just that it's GS, G protein coupled receptor, GS, which by that activates the adenylate cyclase and increases cyclic AMP, and it also activates protein kinase A. And the only red part is the important thing that you need to know. So if they asked you, what do you mean like by blood glucose? What's normal and what's abnormal? So the fasting blood glucose, they would ask you if you want to measure your blood glucose in the hospital, they would ask you to fast for 8 hours. So if they checked it, and if it was between 70 and 99 milligram per deciliter, this is normal. Or by another unit, 3.9 to 5.5 millimole per liter, this is also normal. But if you want to check your random blood glucose, like anytime during the day, even if you're not fasting, it should be between 70 to 140 milligram per deciliter in people who are not having diabetes. Also, the definition of hypoglycemia, it's the blood glucose below 70 milligram per deciliter. And the definition of severe hypoglycemia, blood glucose less than 54 milligram per deciliter. Types of hypoglycemia. So you have three types. The insulin related, it's related to diabetic patients. So if a diabetic patient took excess insulin uh, dose, this would lead to hypoglycemia. And if it's mild case, we can just give any carbohydrates, anything that have just sugar, and they would be fine. But if it was severe hypoglycemia, we need to inject them with glucagon. Postprandial, which means after meal, also we call it reactive hypoglycemia. This is exaggerated insulin release after a meal. Like let's say you took a very sugary meal after you break your fast, like you just drank juice the moment you break your fast. This could happen, like exaggerated insulin release. The patient would present with adrenergic symptoms like palpitations, sweating, and all the other symptoms, adrenergic symptoms, but it's self-limiting. It can resolve by itself. Fasting, like normally someone is just fasting, there could be decreased liver glucose production, or the peripheral glucose and the organs, it's used excessively. So you need to know them by heart. Are they clear, or anything needs to be repeated? Yeah, hypoglycemia is less than 70. This is the definition for hypoglycemia. Okay, great. Like counterregulation during hypoglycemia. So if you want fast, as I mentioned, fast or acute from glucagon, we have the backup system, which is epinephrine from the CNS, and pituitary hormones. We have the ACTH, which releases cortisol from the adrenals, and growth hormone also is released from the pituitary. So all of these hormones, they counteract the hypoglycemia. طيب again, glucagon increases hepatic glycogenolysis and gluconeogenesis in the late stages. Epinephrine increases glycogenolysis, lipolysis, and decreases insulin secretion. And I put it in red as your doctor stressed on it. I think someone has questions. Cortisol. Yeah, they fight hypoglycemia. You are right, yes. Like, if glucagon response is weak, like in patients with type 1 diabetes, epinephrine would be critical in this case. Like their body would release epinephrine instead of glucagon. Like somehow it replaces it. If both failed, like the glucagon and epinephrine, here the patient would have the severe hypoglycemia, which is less than 54 milligram per deciliter. Again, here the same thing, just different names, acute and chronic. Acute is the glucagon and epinephrine. Chronic is cortisol and growth hormone. They are all here to maintain or rise the blood glucose. Again, this is a summary, just you need to know it. Here, the graph here after a meal, your glucose levels increase and insulin level increases. On the other hand, the glucagon levels decreases. Once your glucose levels are decreasing, insulin levels are decreasing, glucagon levels are increasing gradually. And here, this is just a summary. And here we come to questions. Feel free to answer in the chat. B, yes, you are right. It's B because we said that insulin and C-peptide are packed in the granules in equimolar amount, and this is the endogenous insulin. Yes, it's secreted with insulin. Next question. What do you think? No, it's not A. Okay, I'll explain it. Which um, enzyme? We said that it's um, glucose sensor. It's just worded in a different way. So yes, exactly, glucokinase. It's just worded in a bit confusing wording, but we can explain it. So they said pancreatic oxidation of glucose result in an increased release of insulin. Glucose oxidation is glycolysis. Then they said this mechanism is referred to as glucose-stimulated insulin secretion. This is the when glucokinase senses oxygen and it get sorry, not oxygen, glucose. It gets in to the beta pancreatic cells via GLUT2, and it starts producing via glycolysis. It starts producing more ATP, and the cascade occurs. Then they said a defect in which of the following proteins would be expected to exert the greatest negative effect on GSIS. So, which mutation they mean, or which malfunction in these enzymes would lead to negative effect, like this glucose-stimulated insulin secretion would not occur. This is how the question is worded. So it would be glucokinase. Is that clear? Oh, okay, you didn't get it. It's fine, no worries. So let's go back to the slide. So here we said we have glucose, and GLUT2 is called also as glucose sensor, and glucokinase also said it's a glucose sensor. I wrote it, yeah, I wrote it here. Tamam? So when there is glucose, increased glucose levels in your blood, it's going to be sensed by this GLUT2, and it's going to get in. Also, glucokinase senses this glucose and glycolysis starts. Okay? So if there is a defect in this enzyme, glucokinase, GLUT2, okay, the glucose will get in, but will it be converted to ATP and the cascade would go on? Did you get my point? Okay, okay, great. Okay, we're done with the first lecture. Are we all good? We can continue with the next lecture. Okay, perfect. Fed and fast cycle. Okay, fed and fast cycle. Like again, here we said the major energy storage in our body. We have the carbohydrates, we have the lipids, and proteins. Carbohydrates is just a short-term reservoir, and it's in the muscle and liver. But we get our energy if we need it from the liver mainly, not from the muscle. And I kept repeating this. Why? Because muscle lack glucose 6 phosphatase enzyme. It's only found in the liver. Lipids, we store the fatty acids as triacylglycerol in the adipose tissue, and this is the large energy reservoir in our body. Proteins, it's energy for our body, but we don't store it because muscles don't store proteins. Like this is just a slide, nothing high yield here, but you just need to know again that glycogen is short term, fat is the for long term fuel, and protein we use them if our body needs to use them. It's going to be used at the end in starvation and by muscle breakdown and what we call muscle wasting, and we don't tend to use that unless the patient is really starving and our body will start breaking down muscles. So we have three phases in the feed and fast cycle. Absorptive state or absorptive phase, it's also called fed, and it starts 0 to 3 hours. 0 is just the moment, just right now you ate, to 3 hours. Post-absorptive is early fasting, which starts 3 hours to 12 hours, and it could continue up to 18 hours. The last one is prolonged fasting and or starvation. It's more than 24 hours. So in the absorptive state, let me ask you guys, what are the levels of the hormones in this state? Okay, high insulin. Okay. How about glucagon? Okay, great, low glucagon. How about post-absorptive state? Okay, great. Yes, the opposite. And prolonged fasting, it would be the same as the post-absorptive. So again, as your colleague mentioned, in the absorptive, it's high insulin and low glucagon, and this is the storage mode. The post-absorptive, here insulin falls and glucagon rises, and we need to maintain the or regulate the blood glucose. And in the prolonged fasting, glucagon here dominates, and our body starts also to mobilize the fatty acids and ketones. Again, here the same thing, just in stress and exercise, epinephrine is going to amplify the fasting pattern. So again, insulin is inhibited, and glucagon and epinephrine are going to dominate. Also, an important thing we need to look at the insulin and glucagon ratio. So if this ratio is high, we're going to store. If it's low, we're going to mobilize. Stress, yeah. Stress and epinephrine are the same thing with glucagon. Like brain and RBCs. Like RBCs, mainly they use glucose, no other energy source they can maintain their energy from, because they don't have mitochondria for the anaerobic glycolysis. However, the brain during the fed state and the early fasting, it's going to use glucose. But in prolonged fasting, ketone bodies kick in to help the brain get its energy, and also to reduce the demand on glucose to keep it for RBCs, as they can't use any other source of energy. Here, if you ingested 100 gram of glucose, so your glucose will spike, and your glycogen will start uh, to be stored, like your stores are replenished. Uh, this is like around 0 to let's say, as it's written, 3 hours. Then after that, you didn't eat anything until 12 or 18 or up to 18 hours. Uh, this is the post-absorptive. Glycogen stores, it's decreasing. This like beyond 24 hours, gluconeogenesis will kick in, and the synthesis of new glucose will start. So from hours to days. Like here in the absorptive stage, again, there's a pin. We need to memorize this. Liver, or mostly it's better to understand rather than memorizing. Understanding make it very easy. So liver, glycogen synthesis, as we have high insulin. So insulin is anabolic, glycogen is synthesized, and the excess glucose is going to be converted into fatty acids and stored as triacylglycerides in the adipose tissue. Muscles also will uptake the glucose by GLUT4 and has its glycogen replenished, and protein synthesis too. Also adipose. In the adipose tissue, we have triacylglycerides, as I mentioned earlier. We're going to get it from the chylomicrons and VLDL. Chylomicrons is the dietary fat, and VLDL is the triacylglycerides from the liver. And the brain just uses the glucose. Again, here, just a summary for what I mentioned earlier. The post-absorptive, again, there should be a pin here. Here we have decreased insulin and increased glucagon. Now, rather than storing, we're mobilizing. So our goal here, we need to maintain the blood glucose for the brain and the RBCs. The liver will start glycogenolysis, breaking down glycogen. If there is prolonged fasting, like there's starvation or fasting more than 24 hours, there would be gluconeogenesis. By the way, you need to know these, like the hours, so you can know in the question how to solve and what's going on. In the adipose tissue, there would be increased lipolysis, which is the breakdown of fats to get energy, and the muscle. In this state, it's going to use fatty acids, and later on in gluconeogenesis, the muscle will the proteins in the muscle are going to break down, and they are going to act as substrate to support this process. Like here, I mentioned for you since the beginning of the session that we have the direct suppliers for gluconeogenesis are glycerol, amino acids. Here we have alanine and we have lactate. So if they asked you in a question, as one of your practice questions with Dr. Hana, the question was asking for direct substrate for gluconeogenesis. So the answer was, I guess, glycerol in that question. So you need to know these three substrates. It could be any other amino acids, but here we have it as alanine. Clear until now? Alanine, because we are in the muscle specifically. So I just mentioned other amino acids in case it was in the choices in the exam. If there was no alanine, alanine cycle. I think you mean Cori cycle or something. I don't remember exactly, but mostly you are right. Yeah, I think you are right. Yes, Cori cycle. Yes, exactly. This is what I remember. Cori cycle. Okay, so we can move on. Prolonged fasting is starvation more than 24 hours. Here we have the insulin is very low, glucagon is high, and here we have sustained mobilization. So the body is trying to use whatever is there to keep the person alive. So here the glycogen is depleted, liver starts on gluconeogenesis, and lipolysis still remains high, like still the body is breaking down fats. And also the liver would increase ketone body productions. Ketone body production, we're going to get these ketones from the fatty acids. Also, we're going to take this later on, inshallah, in your lectures. The ketone body production, like the exact pathway, inshallah, later on. But for now, just you need to know that the liver, in the prolonged fasting, produces the ketone body production. Brain also uses, as I mentioned earlier, ketones to spare the glucose for the RBCs. Okay, here again, just a summary. The most important thing here that the liver produces the ketone bodies, but the liver can't use these ketone bodies. Why? Because there is an enzyme the liver lacks. It's called thiopurase. You might get asked about this enzyme. So it's thiopurase. Liver produces ketones but can't use them due to the lack of thiopurase enzyme. Again, here just a summary picture. Yeah, thiopurase, yes. طيب. Why blood glucose matters for us? Because the brain, there is high demand, especially the brain. The brain needs it. Like it weighs 2% of the body weight, and it needs it for continuous supply, because if hypoglycemia happened, the brain would be the first organ, if not mistaken, to be affected, and this would lead, if not, if the hypoglycemia is not corrected, the patient would go to coma. And also, yeah, you need to know the glucose transporters for the brain. We have GLUT1 and GLUT3. They're insulin dependent, by the way, the GLUT transporters in the brain. So in the fat state, mainly the main supply for the brain is glucose. Fatty acids cannot be utilized by the brain because they cannot cross the blood-brain barrier. So rather, during the prolonged fasting, the brain is going to use ketone bodies, which are synthesized or produced by the liver. Type in adipose tissue, we can compare during fat and fasting state. So during fat state, there would be an increase in GLUT4 uptake, glucose uptake, and this would provide the glycerol 3 phosphate for triacylglyceride synthesis. And also, as we said, lipoprotein lipase will be activated to store the fat, and hormone-sensitive lipase would be deactivated when there is insulin, because we don't want any energy right now, we're just storing. On the other hand, if we're in fasting state, this would be decreased, the R would be down, lipoprotein lipase will be down, hormone-sensitive lipase will be increased because we need energy. Again, this is what I just mentioned. Here, hormone-sensitive lipase will be on. And this is a summary. And here we go. Skeletal muscles. Like during fat state, we need to uptake glucose. glycogen will be stored and will have protein synthesis. And early fasting would have the shift for fatty acids to spare the glucose for brain and RBCs. So the muscles will use mainly fatty acids during the fasting state, the early fasting state. And in prolonged fasting, they will use ketones uh, to help reduce the net protein loss. So the muscle store glycogen for itself, but it can't release it to the blood due to the loss of that enzyme I just mentioned, glucose 6 phosphatase. Again, here, just a summary. Summary again. This is a summary by Dr. Hana. On this table, Dr. Hana, when she taught us, she gave it. It's a nice summary. You can go over it. Just يعني, give it a quick look before your exam. When they ask about the well-fed state for the liver or any other organ, you know it. And for the fasting state, also, it's the same thing. Now, do you have any questions before we go to the questions themselves? So yeah, they mainly RBCs rely on glucose. They rely on glucose like by glycolysis, but they don't have the mitochondria for anaerobic. Uh, sorry, you mean they rely on glycolysis? Mainly, they have just the glucose for their energy, but anaerobic, in anaerobic state, they can't do it because they don't have the mitochondria. Did you get my point? Okay. Any other questions before we start solving? I think. Okay, great. Okay. Read the question and give me your answer. Yes, you're right. So this this man, he's fasting about 8 hours. Um, yeah, post-absorptive stage, exactly 8 hours. So his blood glucose is normal, and why is that? Because the liver breaks down the glycogen into glucose. You're right. Excellent. When does it becomes gluconeogenesis? So yeah, gluconeogenesis kicks in the starvation state, or if someone is fasting more than around like according to your slides, if someone is fasting 3 to 12 hours, or sometimes up to 18 hours, this is the post-absorptive stage where we have the glycogenolysis. But if it's at the end of it, the gluconeogenesis could kick in, like the before the 18 hours, and then it could continue if this person fasted more than 24 hours. Is it clear? Okay, great. The next question. Yes, it's B. Fatty acids cannot cross the blood-brain barrier. Exactly. So instead of that, the brain would use the ketone bodies. Next question. Yes, ketone bodies are in starvation mode. Yes, B. And what about the other two um, direct substrates? I mentioned them, amino acids and lactate. Exactly. Excellent. Good job. Last question, I guess. Mhm. Yes, B. We said that the liver produces ketone bodies and cannot utilize them due to the lack of thiopurase in starvation state. I just copied these questions from your slides. So it was some practice questions from Dr. Hana's slides. I thought putting them here would be nice for discussion. So are you all good? We can go with the third lecture anytime. You're welcome. a break for 5 minutes. Okay, good. Inshallah, this part is easy. We can go with it. So metabolism and diabetes. Like, if they told you to define what is diabetes or diabetes mellitus, it's characterized by elevation of the fasting blood glucose. تمام. Fasting blood glucose would be than 26. If it was more than 26 milligram per deciliter, this would be the definition of diabetes mellitus. It could be relative or absolute deficiency. Relative means like there is insulin, but not the normal amount. Absolute means like no insulin at all. The diabetes has complications like blindness or amputation, blindness due to cataract formation, and amputation due to gangrene formation. It's a major cause of renal failure, heart attack, and strokes. So it's always a risk factor. So there are two types of diabetes. We have type 1 and type 2. Type 1 is solely insulin dependent, and type 2 is called non-insulin dependent. There is insulin, but there is resistance for this insulin. The body can't use it. So how to diagnose it? There are three things you're going to look at. The fasting plasma glucose. So as I just mentioned, 126 milligram per deciliter fasting plasma glucose or blood glucose. If it was more than 126, this could be A1 positive in the diagnostic criteria. Glycosylated hemoglobin, which is HbA1c. If it was more than 6.5, an oral glucose tolerance test. This when you give a patient a oral glucose solution, and you measure the glucose after 2 hours. If the glucose was 200 or higher than that, this is one of the diagnostic criteria too. Also, you can do urinalysis. So if the patient blood glucose was 9 to 10 millimole per liter, or it was 160 to 180 milligram per deciliter, you suspect that the glucose would appear in urine when you do urinalysis, because there would be saturation of the SGLT transporters, and this would lead to glucose spilling in the urine. So it will be positive in the urinalysis test. Again, I just mentioned that HbA1c is glycosylated hemoglobin, means that there is glucose attached to the hemoglobin, and it's proportional to the average blood glucose over the previous 3 months. So you measure it every 3 months to check if the treatment is going well, the patient is maintaining his blood glucose well, he's taking his medications, and that's for this the test. So we have the first type of diabetes, which is called type 1 diabetes. It's an autoimmune attack of beta cells. So the patient might have a viral infection, past viral infection, and also the patient is genetically predisposed. So these both should be there, and type 1 diabetes would occur. So when you look at the beta cells or the islets of Langerhans, you would see infiltrates of activated T lymphocytes and what we call insulinitis. Insulinitis, when you see the ITS, means there is an inflammation of the islets of Langerhans. So there is gradual depletion of B cells, means step-by-step depletion of B cells. Once the patient have 80 to 90% lost the beta cells, here type 1 diabetes would appear. Or if they told you that there is the viable beta cells are 10 to 20%. Also, this is type 1 diabetes. So in this case, type 1 diabetes, the pancreas fails to respond to the high glucose. And in this stage, the patient needs to take the insulin therapy. Also, the patient would present in early childhood or puberty, mainly would be like less than 30 years old. Like here, insulin secretory capacity during the onset of type 1 diabetes. As I just mentioned, like here, the child is born and let's say, and also here the insulin capacity is good, 100%. At the stage of his early life, he gets a viral infection or toxin somehow. تمام. The beta cells gradually will start to be destructed, and also make sure that the patient also have a genetic predisposition alongside this infection. So the beta cells will gradually start to get destructed until they reach around 80 to 90% of destruction, and the signs and symptoms of type 1 diabetes will appear. So this is what I just mentioned, that you need to have the viral infection and genetic determinant, and this allows the recognition of the beta cells as non-self. So the body recognizes these cells as they're not part of the body. So they will start to attacking them, autoimmune antibodies. Okay, they will attack the beta cells. Also, when they looked into the monozygotic or identical twins, they found that one sibling developed type 1 diabetes, other one has around 30 to 50% chance of developing it. However, in type 2 diabetes, inshallah, now when we see, the monozygotic twins will have both of them, yani if one developed type 2 diabetes, the other one will have 90% of developing type 2 diabetes. Also, I mentioned this, the patient would be childhood or in puberty. The symptoms would be polyuria, frequent urination, polydipsia, the patient would be excessively thirst, and polyphagia is excessive hunger, and this triggers the illness. Also, there would be like fatigue, weight loss, and weakness. Diagnosis is confirmed by the fasting blood glucose, which is more than 126 milligram per deciliter, or the other hospitals might use the other unit, which is millimole per liter. The normal range, I think they will give you the normal range in the exam, but just know it just in case, 70 to 99 milligram per deciliter. HbA1c, the normal is less than 5.7, and the abnormal would be more than 6.5 milligram per deciliter. Um, yes, you are right. Like the symptoms, we said just now about the SGLT transporter. So the SGLT transporter would be saturated. This would lead to, rather than absorbing, the glucose will start spilling in urine. And glucose also act as an osmotic agent. Osmotic means it withdraw water. So this would lead or contribute to the water loss or contribute to the polyuria that the patient might complain of. And also the patient would be like thirsty and want to drink water too much. And yeah, that's it for this part. Again, we just mentioned this, the effects of insulin on carbohydrate. You can go over it. And also this is the effect on lipids. Remember again, the uh, hormone sensitive lipase, it would be inactivated if there is insulin. If there is no insulin, if there is insulin, hormone sensitive lipase will be inactivated. If there is no insulin, if there is insulin, sorry, lipoprotein lipase will be activated. طيب, here again, the metabolic changes. You would see these metabolic changes specifically in liver, muscle, and adipose. We have also hyperglycemia and ketoacidosis are the hallmark of untreated type 1 diabetes. Ketoacidosis would lead to something called diabetic ketoacidosis. So if they told you there is a patient with type 1, or let's say they didn't tell you the diagnosis, they told you there is a patient, 30 years old patient or 29 years old patient presented with hyperglycemia, fruity breath smell, came to the ER, and he also mentioned that there is, or his family members mentioned that he has a polyuria, polydipsia, polyphagia, and labs showed there is increased levels of acetone. What would be your diagnosis in this case? Yes, it's type 1 diabetes mellitus, also caused, and the symptoms are caused by ketoacidosis. So when they tell you fruity breath smell, this is due to the acetone, or these ketone bodies are produced in the body. So also sometimes the fruity breath smell could be mistaken for alcohol toxicity, but mainly it's due to diabetes type 1. Ketoacidosis does not occur in type 2 diabetes. It's only related to type 1 diabetes. So since we don't have insulin, there would be increased gluconeogenesis and diminished peripheral utilization. So the organs like muscle and adipose tissue cannot utilize the glucose due to the lack of insulin. And ketosis results from the mobilization of fatty acids in the adipose tissue. As I mentioned, you're going to learn more about this, but the fatty acids basically are going to be converted into these substrates, or these products, 3-hydroxybutyrate and acetoacetate. These two contributes to the diabetic ketoacidosis, and sometimes it could lead to coma too. طيب, so the fatty acids, we have them, are not all flooded in the liver, so they can be converted into triacylglycerides and get backed into the VLDL by the liver. So since we don't have, this is in a normal individual, and this occurs by lipoprotein lipase, but in an individual with type 1 diabetes, there is no insulin, so this hormone won't be working. And this would lead to something called hypertriglyceridemia, or triacylglycerolemia, which is same as cholesterol. So giving these patients insulin would be the therapy or the treatment, and everything would return to normal. Insulin will activate this enzyme, and it will the excess fatty acids are going to be packed in VLDL, and their plasma cholesterol or VLDL levels are going to be normalized, or LDL, sorry. Here is also a summary of what we mentioned, and here again, the treatment would be either the insulin pump or the injected insulin, exogenous. Again, here is the therapy, which is insulin. Uh, Also, the secretion in a normal individual, if there is hypoglycemia, the compensatory mechanism would be we're going to have the glucagon release and epinephrine. But patients with type 1 diabetes, over time, they have weak glucagon secretion, or it could be impaired even. Also, the epinephrine secretion would be impaired. This is called, in a term called neuropathy. Neuropathy means that the epinephrine secretion is diminished. We don't have secretion anymore. So these patients are vulnerable to hypoglycemia. So we ask them to keep something sugar in them just in case. So now we come to type 2 diabetes. Is type 1 diabetes clear, or anything needs to be re-explained or be cleared? Clear? Okay, great. Type 2 diabetes. So it develops gradually. There are no obvious symptoms. The patient would be mostly more than 40 years. It's contributed. There are many risk factors, like obesity is the main one, which would lead to insulin resistance, and this would lead to like dysfunctional beta cells. Some patients would present with symptoms like type 1 diabetes, which are polyuria and polydipsia. But to rule out type 1 diabetes, look at the age in the question when they mentioned. We said in type 1 diabetes, it's mostly 30 years and below, or 30 years or below 30 years. In type 2 diabetes, mostly it's more than 40 years of age. Like here in type 2 diabetes, they don't require insulin, but they would require lifestyle modification and anti-diabetic agents, which we're going to look at the end of the lecture, inshallah. So metabolic alteration would be observed in type 2 diabetes would be milder than the one we said in type 1 diabetes. And I mentioned that there's no ketoacidosis in type 2 diabetes. Okay, because we have insulin here in type 2 diabetes, but the organs cannot utilize um, the, uh, the insulin. Okay, next we have here the diagnosis. The diagnosis is based on hyperglycemia. So the fasting blood glucose also would be more than 126 milligram per deciliter. But let's say we found that the patient has the fasting blood glucose between 100 and 125. So we don't term them as diabetic patients, we term them as pre-diabetic patients. Okay. Um, so here we don't have any autoimmune antibodies or viral infection. It's just unknown etiology. Uh, Later on, they started saying that it's just insulin resistance, but nothing other than that. So the major contributing factors to hyperglycemia is insulin resistance in peripheral tissues like the liver, muscles, and adipose tissue, and inadequate response of beta cells to secrete insulin. Like in insulin resistance, again, this is should be a review since there's insulin resistance, the liver and adipose tissue and the muscles, they cannot respond properly to the insulin. So there would be decreased hepatic glucose production, decreased glucose uptake by the muscles and adipose tissue by GLUT4, and there would be increased adipose lipolysis, the breakdown of fatty acids. So here are the risk factors. You need to look for them. If the patient was obese, look in the question, the patient was obese, old age, 40 years and above, physical inactivity, they would say sedentary lifestyle, pregnancy. Any questions? Genetics. Genetics here mainly, I'm not sure if it's involved يعني 100%. Like, I guess both would be there because we mentioned in monozygotic twins, since it's there in monozygotic twins. So I think it also would play a role in also other individuals. Like if their family members have type 2 diabetes, they will get type 2 diabetes. This is from what I know. Also in pregnancy, there would be something called gestational diabetes, as we're going to see further in the slides. There would be a complication called microsomia, or like the big baby. This would lead to some complications during delivery. Like here we have the insulin resistance and obesity. They play an important role in type 2 diabetes. So if the patient is obese, there are some changes in the adipose tissue secretions that would result in this insulin resistance. So first thing, the thing that would occur is obesity plus genetic 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 abnormality. Okay, as from what I know. So this would lead to the increase of the pro-inflammatory cytokine, which is interleukin 6. And in addition to that, there is decrease in the adiponectin. Adiponectin works as an anti-inflammatory substance. It's decreased, and the interleukin 6 would be increased, which is pro-inflammatory. It increases the inflammation. And this also contributes to the insulin resistance, which would occur at the end. Like if we looked at this graph, we're going to see here the red is the obese individual and the blue is the normal individual. Here we have the insulin levels, and here we have the glucose levels. Both of these individuals, they have the same insulin, same glucose levels, but the obese individual have higher secretion of insulin due to the insulin resistance. His body is trying to maintain the glucose levels, while the normal individual, which is the blue one here, his insulin levels are in the normal range. Is that clear until now? Or anyone have a question or something needs to be cleared? Obesity. So yeah, not every obese patient would get type 2 diabetes. تمام. So an obese patient needs to have a genetic predisposition so they can have insulin. They will have type 2 diabetes. Would they all have insulin resistance? They could have insulin resistance, but not all of them would develop the type 2 diabetes. Did you get my point? Yes, it does increases the inflammatory cytokines, and this would lead to insulin resistance. But will that lead to type 2 diabetes in all the patients? From my understanding, uh, there should be a genetic predisposition, so it's not necessarily, yes. Okay. Like here, and we look to this graph, we have here glucose, and here we have the insulin secretion. Like this is in an obese patient. So here are the levels of the glucose. So here it starts by the patient starts by having, if there's low glucose, it's also here low. Then the glucose starts to increase, and here also the insulin starts to increase. It increases more than normal. If you can see, it's here 200, the level of the insulin 200, and then here the insulin, the glucose still increases, but since there is resistance, the beta cells cannot do more than what it's doing, so it's going to be destructed, and the levels of insulin are going to decrease below the normal, or like could be there could be no any insulin secretion more than what's being secreted, and the plasma levels of glucose are going to be high. Also here there are the complications of type 2 diabetes. So here you have the insulin resistance. You need, as your doctor here mentioned in this picture, you need to have genetics. And there could be obesity, sedentary lifestyle, aging. This could be, all of these could be mentioned in a question, like as keywords to get into the final right answer. So all the one of these is here with insulin resistance. That this would lead to hyperinsulinemia, but still there is impaired glucose tolerance, decline in beta cell function. Also, there would be genetics or glucose toxicity, free fatty acid also toxicity, and this directly will lead to type 2 diabetes. These are more clinically oriented, but just you need to know them. If you saw them in a question, what are the microvascular complications? Like microvascular means the complications that occur in small vessels, retinopathy, eye problems, neuropathy, neurons, and nephropathy is related to kidney. Macrovascular are in large vessels, cardiovascular disease, and stroke. So here also, this is what I wrote for you. Not all obese individuals will develop diabetes. They need to have a genetic factor too. So as a result of the insulin resistance, which is expressed primarily in the liver and muscle and adipose tissue, there would be hyperglycemia, dyslipidemia, and sometimes you could have ketosis, which is not diabetic ketoacidosis itself. It could be here minimal or absent even, because insulin is present, as I mentioned for you. Just it's the tissues cannot respond to the insulin. Here, just as a summary, uh, how do we treat patients with type 2 diabetes? As I said, dietary modifications, exercise, weight loss. This is in the early stage, like once you diagnose them. But some patients can require the antidiabetic drugs, which we'll see them now. In severe cases, if all beta cells are depleted and no more they're responding, we're going to give the patient insulin therapy. So here are the antidiabetic agents, very high yield, you need to know them. The mechanism of action is very important. So before we start in the agents, anything needs to be clarified in the previous part? Okay, great. Like, First drug, and it's the first line medication. It's metformin. It inhibits the hepatic gluconeogenesis. So it inhibits the formation of new glucose. Next, we have the sulfonylurea. They bind to that um, potassium channel I showed you in the beta cell, which is ATP sensitive potassium channel. It increases insulin secretion. So if they ask you what's the mechanism of action of sulfonylurea, it could be increase insulin secretion, or they might tell you it binds to the ATP sensitive potassium channel and blocks it. So either this or this could be in the choice, يعني one of them, or both would be in the same choice. Its side effect, it leads to weight gain and increased risk of hypoglycemia because it increases the insulin secretion. There is also something called pioglitazone or thiodinodiones. I don't know how it's pronounced, but basically pioglitazone. So it decreases the insulin resistance. This is its يعني mechanism of action, but the side effect, which is recognized in patients, it increases the risk of heart problems. So they don't use it a lot due to this risk factor. Also, there is GLP-1 agonist. We have semaglutide. Also, the drugs that are used for weight loss, like Ozempic and all of these, they are GLP-1 agonist. So the mechanism of action, it increases glucose-dependent insulin secretion. Side effects, it reduces the appetite and promote weight loss. Also, DPP, 4 inhibitors, gliptins, it increases the endogenous GLP and GIP levels. So they are secreted by the intestines, and they lead to increased glucose-dependent insulin secretion. So both these drugs increases glucose-dependent insulin secretion. Finally, we have the SGL2 inhibitors, flozestin. It blocks SGL2. We said earlier, SGL2 works as a transporter for absorbing glucose, but blocking it would lead to glucose secretion in the urine, like increased renal excretion of glucose. Okay. Then here, just the complications of diabetes. We just mentioned them, the microvascular and micro and macrovascular. So premature atherosclerosis. So this is just a blockage of the vessel by a fat streak. This would lead to cardiovascular disease and stroke. There also would be retinopathy, eye problems, nephropathy, kidney problems, and neuropathy. The neurons problems. Finally, here we have the gestational diabetes, which occurs during pregnancy. So this would lead to something called fetal macrosomia. So as you can see here, the fetus or the baby is large, like big baby. This might lead to complicate the delivery, and sometimes instead of normal vaginal delivery, they would go to the C-section delivery to avoid further complications. Finally, here, diabetes prevention. How we can prevent diabetes? We need to, for type 1 diabetes, no preventative treatment, but for type 2 diabetes, there is combined regimen, which is, we said, the diet, weight loss, exercise, and we need to control the hypertension and dyslipidemia or cholesterol if the patient does have them. So if you looked in this graph, you have here the body mass index or the BMI, and here the incidence of developing type 2 diabetes. So if the patient have body mass index less than 24, and if the individual, either if he's having little exercise or moderate or extensive exercise, this patient like most likely won't develop type 2 diabetes. For a patient with BMI of 24, between 24 and 25.9, if the patient is having little exercise or moderate exercise, the risk would or the incidence would increase. However, a patient with extensive exercise, the incidence would be a little bit lower than these two. A patient with a BMI more than 26 and having little exercise would have very high incidence. And an individual with moderate exercise and BMI of 26 would have a little bit lower incidence than the little exercise. And finally, the extensive exercise individual would have a little bit lower incidence than the other two. Okay, and this is a summary by Dr. Hana. It was at the end of your slides. Also, these tables are really good summary and a comparison for review. Summary of treatment. Please try to note the treatment and whatever was in red in my slides or whatever has been signed. You could get asked about it. And that's it. Anything needs to be clarified before we go to questions. Okay, questions directly. Okay, great. B. How about this one? Yes, it's A. Right. Good job. Yeah, I just got it from a textbook. So you just need to adjust yourself how the questions are worded. And that's it. We finished our session. Please scan the QR code for your feedback, for anything that's need to be improved. And if you have any questions, please feel free to reach out for me. And that's it. You're welcome anytime. Thank you so much.